Yeah, I can see that you started. Lovely. 1 second. Okay, Isha, you okay if I start?
Yep, go for it.
Lovely. Okay, so we just wanted to start with a little introduction to behavioural science. Are you sharing your slides, Isha? Yeah, okay, cool. Sorry, I couldn't see them then. That's fine, I can see them. Yeah, so I just wanted to start with an overview of what is behavioural science. So behavioural science is the study of behaviour, which enables us to understand what allows a behaviour to be performed, what prevents it, and how the behaviour can be maintained. It also involves us collecting, using and analysing data to understand behaviour through models and theories. Behavioural science can be used to optimise policies, services and communications, and obviously that's what we do here at Birmingham City Council in the Public Health team. So I just wanted to start by asking and offering some response maybe in the chat, or if you want to put your hand up. What do we think influences behavioural change? Yeah, what's people's opinions on that? What do we think are the big influences?
Feel free to chat, put something in the chat, or put your hands up if anybody wants to shout out their thoughts. Yep.
Yeah. Motivation's definitely a big one. And obviously I think we'll come on to speak about that later. Policy, yeah, especially in a public health setting as well. I don't know if I'm missing any, because I don't know if I'll just see them when they're like sort of come through.
Yeah, capability. Yeah, we've got capability coming out, cutbacks, beliefs.
Yeah, that's a big one. Sort of beliefs in general, but sort of could be linked to religion, culture, those sort of things.
Yep, finance, social influences.
Yeah. Yeah, peers, social support, TikTok, yeah. That can definitely be one. Social media is such a big influencer, which can be positive as well. It can be a positive thing. Any more, Isha? Or?
No, I think we're probably good.
No, yeah, so I think, yeah, where you live, geography, that's definitely one. 100%. And that, I think that links to like cultural norms as well. And there's other things as well, like time, income, your environment, as we've said, family and friends, and then social norms that are linked to that. Maybe something like self-efficacy, knowledge of behaviour, and as we said, motivation. Yeah, I think everyone's covered them all. That was brilliant. So we'll move on to what is behaviour change. So behaviour change is doing something which causes you to behave differently. So this could be things like problem solving. So it helps us to figure out why we do certain things. Behaviour change is really broad, so it can be applied to lots of different situations. And it's really valuable. So we should always try to think about it when we're trying to improve things. Which leads us on to what behaviour change is not. So it's definitely not a silver bullet. So it's not the answer to every problem. And it's not standard. It's not sort of, it doesn't work with a one size fits all approach. What works for one situation might not work for another. It's not judgmental. So it's not meant for us to be like harmful or criticise or hold judgment. And it's not exclusive. So anyone can change their behaviours, not just experts. So why is behaviour change important? So we need to support individuals to live a healthier and happier life. And we can do this by supporting them with healthy behaviours. So this could be things like, for example, healthy eating, so like 5 portions of a variety of fruit and veg a day, not smoking, you can live up to 10 years longer compared to smokers. Physical activity, 150 minutes of moderate intensity activity a week, or 75 minutes of vigorous intensity activity a week. and limiting alcohol intake, so maximum of 14 units of alcohol a week across 3 days. So things like this we can link into many public health outcomes, and if we can effectively target behaviours, this can lower the risk of health issues such as seen listed, such as things like heart disease, type 2 diabetes, mental health illnesses, just to name a few. So I'll now pass you over to Isha on how we can implement behaviour change interventions.
Brilliant, thanks, Alicia. So now that we've had a little bit of an introduction to behaviour change, and perhaps a refresher for some of you, we would like to think about where we can use behaviour change interventions. So we can use interventions to target individuals or at a population level targeting communities. So at an individual level, you may have heard of making every contact count or motivational interviewing. So these are behaviour change interventions delivered at an individual level through one-to-one conversations. Other examples include those that support people to monitor their current health behaviours, set goals, and receive social support. So, for example, this could include a one-to-one appointment with a health professional, encompassing making every contact count and raising awareness of relevant health risks to increase knowledge that may be outside of what the initial consultation was for. That was set up for. We can also think about environmental level. So these interventions are found in our surroundings, and they often nudge us towards a desired behaviour or away from undesired behaviour. So examples of this includes outdoor gyms, cycle tracks, healthy foods in a supermarket. So making sure that they're placed in a way that's easy to be seen by customers, and also easy to reach, and perhaps the pricing is affordable and kind of encouraging to individuals to purchase. Behaviour change can also influence policy, and this can include legislation. So, for example, the seatbelt law and the smoking ban, and also different campaigns such as the Change for Life and messages displayed on cigarette packs. So there's a variety of different types of types of interventions that can be conducted, and thinking about the type of approach specific to the targeted audience. So there's various kind of frameworks out there that support the development and the design and development and implementation of various behaviour change interventions. So some of you may have heard of the COMBI model. This is a model that can be used when thinking about understanding barriers and facilitators to specific behaviours, and also thinking about intervention design. So this model proposes that there are 3 components to any behaviour: capability, opportunity, and motivation. So capability, individuals must feel they are able to do a behaviour. Motivation, opportunity is that individuals must have the chance to do the behaviour, and motivation, as suggested, is that individuals must want to do the behaviour. And so these interact with each other as components, and we must target one or more of them in order to change and maintain behaviour. This model is widely used in the behavioural science community, and it's the model that we primarily adopt here at Birmingham City Council, and allows us to compare to other interventions and work done by colleagues across the field, and also allows us to think about and compare interventions that we develop, that we design, develop, and implement as well. So just thinking about each of those components in a little bit more detail before we move on. So capability, as I mentioned, individuals must feel like they are able to do something. So this is broken down into 2 components, so psychological and physical. So do individuals have the right skills and knowledge to enact a certain behaviour? So, for example, do they know about the impact of immunisation on an individual and the community's health? Do they have the physical and mental ability to do what we're asking them to do? And do they know how to do it? So if we're asking somebody to engage in a behaviour, but for example, we want them to do a specific fitness routine, but they don't have the knowledge or the skills inherent in order to actually go out with that, to be able to proceed with those behaviours. So we need to think about all these components when thinking about capabilities. When thinking about opportunities, so this is having the chance and the right set of circumstances to engage a behaviour. So this will be influenced by social factors and physical factors, such as the family, community members and leaders, faith leaders. So in terms of physical opportunities, does our environment allow us to engage in a behaviour, the location, resources and time? So we've got to think about are the right people around individuals who will support them or prevent them from carrying out the behaviour? Are the physical resources there? Is it the right environment to do them for what we're asking them to do? And finally, motivation. So we want to ensure that individuals want to do the behaviour. So this is broken down into automatic motivation and reflective motivation. So automatic motivation is about, what it kind of says on the tin. It's those automatic decisions that are made quickly based on desires, impulses, whereas reflective motivation, there are slower, more deliberate, such as making plans. So we might want to think about, do we have the right motivation to do what's being asked of us? Do we want to do it? Are we going to be able to build those habits to do these specific behaviours? So thinking about that, and all these factors then influence behaviour. So if we think about an example where we can apply this to, so something that Alicia and I and colleagues in public health have been working on a lot is thinking about vaccine hesitancy or immunisation. So thinking about the combi model in that context. So in terms of capability, we might want to think about, do individuals, do communities understand why it's important to get immunised for themselves, for others in the community? Are they able to walk? Are they able to take the bus? Do they know how to get to the appointment? Are they aware of the different modes of transport? If they're not able to walk or take the bus, are they able to get, somebody to support them to get to the appointment? So that will influence whether someone is capable of getting immunised. In terms of opportunities, do individuals see other examples, influential people in their community getting immunised? So again, faith leaders, family members, friends, colleagues, and do they have the time to go to the appointment to get immunised? And motivation. So do individuals see contracting an infectious disease as a risk to their health? Are they aware? Do they have the knowledge to understand, kind of the health literacy aspect of it, that how immunization is going to impact their health and well-being? And do they have experiences of fear and anxiety, especially after COVID-19? There's lots of kind of vaccine hesitancy and fatigue, or maybe kind of experiences that impact how they feel about immunization in general. So these are all kind of things that we want to think about when we are targeting, when we're thinking about a certain behavior, and we're thinking about interventions that we can design to target this kind of idea of vaccine hesitancy. So when thinking about an intervention or interventions to support and to address vaccine hesitancy, in terms of capability, we'd want to increase knowledge and understanding. So we could, perhaps do training sessions from trusted sources on risks and symptoms for various things such as flu, MMR, COVID-19. This is something that we've been involved with, with the wider public health team, delivering, as part of the measles outbreak in Birmingham, and that's, to kind of increase that knowledge and kind of address those barriers in terms of capability there. Providing clear direction on how to get to an appointment. So, and kind of ensuring that various routes such as walking and bus and driving, but if that's a barrier, that's associating whether someone's attending their appointment, that could be a way, an intervention to address that capability. In terms of opportunity, we might want to think about providing examples for people to aspire or imitate. So, for example, identifying key influences in the community or places of work, such as health workers and members of the community, and using them as ambassadors to support the message that we want to give. Creating an environment and opportunities to reduce barriers. So for immunisation, accessing appointments. So, for example, a place of work or an organisation might employ agile working to get immunised in work hours to allow appropriate times and ensuring that if a clinic is only open 9 to 5, that individuals have the opportunity to access those appointments. And when thinking about motivation, we think about increasing the knowledge again. We could do this through a poster campaign, identifying the risks and the symptoms of the flu, MMR, or whatever it is that we might be targeting. And we might want to think about including messages to influence feelings and actions. So, for example, highlighting our kind of community responsibility. So, for example, for individuals who are unable to get immunised, for example, getting MMR during pregnancy, we're doing our bit for our community. Whoever can get immunised, we should do our bit and ensure that we're supporting not only ourselves, but our wider community as well. So these are different types of interventions that we might want to consider for this specific case study on vaccine hesitancy when thinking about how we can use the COMBI model to think about that. So that's a little bit of an introduction to behavioural science and kind of our approach in the Birmingham Public Health team. So before we move a little bit further, we thought it might be useful for to give a little bit of a background of how we've kind of come to these roles and kind of what our backgrounds are, that a little bit about that and how we've joined the kind of our experience getting to the behavioural science team in public health. So my background's are kind of rooted in psychology. So I did my undergraduate in psychology, my master's in health psychology. I did that over 2 years. So whilst I did that, completed my master's, I did various bits of work experience, such as working as a support worker with South Asian elderly women who kind of experience stress, so kind of doing different bits of behaviour change techniques with them to implement physical activity in their everyday lives, a bit of lecturing and a voluntary research assistant. And as a part of my master's, my dissertation was on the needs assessment on relationship and sex education for South Asian females. And this came as a result of my volunteer work that I was doing at the time. I had gone to a school to do data collection on contraception with school-aged pupils, and I had a cohort of individuals come up to me and say that we've filled out as much as we can, but actually this isn't really relevant to us. So I spoke to the head teacher, and we designed a kind of research proposal that would allow me to be able to conduct a piece of work for my master's, but also be able to provide recommendations that are practical for them to consider when thinking about relationship and sex education for this cohort of students in their school. I then went on to secure a place as a research assistant at the Applied Research Centre in Health and Lifestyle Interventions, and I was primarily based on the Studies in Adolescent Sexual Health Research Group, so various bits of sexual health research. So, for example, aiming to bring about a social change to mark the end of FGM in various communities. So, working with lots of partners, European partners, to think about to identify the different stages of change in each community, and then identifying suitable interventions to target specific behaviours. Also worked on working on web apps and websites and thinking about, from a health psychology, behavioural science perspective, of how we can increase uptake of sexual health services in young people. I also worked on breastfeeding research groups, so thinking about evaluations and working with new South Asian mums, thinking about their infant feeding decisions. So lots of kind of public health outcomes being considered, but in a different kind of environment and very much focused on research. This then led on to my PhD in factors affecting safe sex decision making, so looking at condom use, barrier methods, and thinking about the contribution of sociosexuality, haemophilia, and specifically the outcome expectancies of condom use and intentional bias, and understanding condom use intention and behaviour. So all these kind of, like I mentioned, kind of the the public health outcomes I've been working kind of considering over my career led me to a role in public health, originally in community engagement, then led on to the wider determinants and thinking about housing and homelessness, physical and built environment, health and our policies and transport, these various areas, but thinking about how we can influence health, and also at the same time thinking about behaviour change strategies that can influence, being kind of the only behaviour change kind of individual with that background there, and kind of waving the flag for behaviour change, but thinking about, you know, still being able to bring that into conversation and kind of work with colleagues on understanding the impact of that and how that can be influenced in our day-to-day job in a public health setting without a behaviour science team. So it was really lovely to once I was able to kind of join this team, to focus primarily on behaviour science and be able to kind of have a team dedicated to working across public health and wider, to influence behaviour change in health. So I'll pass it over to you now, Alicia.
Thanks, Isha. I don't have quite as much as experience as you, Isha, in my career in psychology, but as Isha said, I am also, my career sort of like deep rooted in psychology. So I did a 4-year sandwich course in psychology over at Aston University. So that meant that in my 3rd year, I did a placement. And that placement was as an honorary assistant psychologist at Birmingham Children's Trust in the therapeutic and emotional support services. So yeah, I worked in sort of looking into therapeutic parenting with adoptive parents and foster parents, and that led me nicely onto my 4th year at Aston, and my dissertation research project investigating parenting styles, and the need for the therapeutic parenting approaches, even in obviously with children that aren't in the foster system. And then after that, I went straight on to doing my master's in health psychology back at Aston, so my 5th year at Aston. And within that, I did my dissertation research project. I worked alongside Walsall Council to investigate their supporting family services, which was previously called Family Hubs. And I was looking at the barriers and facilitators surrounding this service, and the attitude. So I did some interviews with people that were within the service or people that had left the service, and how it helped them. And then after that, I did a volunteer placement as a qualitative research assistant, again back at Aston University, looking at the importance of health psychology careers, which led me nicely onto February 2024, where I started this job as a public health officer in the Behavioural Science Team at Birmingham City Council.
Brilliant, thank you. So Alicia and I are we're fairly new to Birmingham City Council, but I feel like we, you know, it kind of feels like we've been here for a lifetime in the short period that we have been here. Yeah, so that's a little bit about our background, so help you understand kind of our journeys and joining a behavioural science team here at Birmingham. So we thought it'd be useful to talk a little bit about our projects that we're working on. So we employ a gold, silver and bronze model in this team, the behavioural science team. So the gold project is kind of, it's a primary piece of research that we're focused on, and that, you know, that kind of spans across the whole team. And then we have silver projects, which we're not leading on as a behavioural science team, but we're supporting with kind of our expert advice and thinking about how we can support other teams in being able to embed behaviour change and look through a behaviour science lens on a particular piece of work. And then we have bronze projects, which are kind of elements of, you know, upskilling and ensuring that, you know, we're kind of visible as a behaviour change team, and we're able to support our colleagues and kind of being able to demonstrate how we can be supportive, because, you know, we recognise that we're a fairly new team. This team has been at BCC since for a year and just over a year and 2 months, so it's a fairly new team. Just ensuring that, you know, it's quite colleagues feel comfortable in knowing what our team is about and how we can support them. So our gold project for the last financial year, which, you know, we're still dipping in to finish, which is kind of it's been a lesson learned, but we can talk about that later. It's to do with implementing an educational intervention aimed at professionals working in GP practices, working with the remaining communities, and those GP practices are in the Washwood Heath area. So we recognise the reason why that specific PCN was identified as the focus for this piece of research is in the previous measles outbreak in 2017, 2018. At the beginning of the outbreak, this community was the highest the highest cases were in this community. So we had identified that actually within this PCN, there's a high number of Romanian members of the community there. So we would focus on that that PCN primary care network to recruit our health professionals from, and not health professionals only, any professional working in the GP. So our inclusion criteria was working in the Washwood Heath area, having direct contact with parents and caregivers as part of their job role, and their job role offers the potential to engage in MMR vaccine promotion conversations. So we applied motivational interviewing into practice. So motivational interviewing is a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. So this is a individual level intervention. So this, as I mentioned, this is a primary piece of research that we worked with various partners across public health teams, such as the health protection team and the wider system. So working with our integrated care system colleagues, working across the public health team, health protection, and beyond, to ensure that we had the right people around the table to be able to deliver this effectively. This included having Birmingham City University on board as our kind of academic colleagues. So, you know, helping us with the ethical process with that. And this particular project had to obtain NHS ethics as well. So that was quite a long period of time, a piece of work to ensure that that was all in place. So once we had all our ethical approvals in place and we were ready to deliver the intervention, we and once we recruited, we were able to collect pre and post intervention data, deliver the intervention, and now we're currently in the process of the evaluation part of this study. So Birmingham City University are doing an independent evaluation on this piece of work, which they are going to be being able to report on the impact of this intervention on individuals that took part. So a little bit about the content. So there was various, I'm only going to talk about it for a few minutes here, but this is an extensive piece of work. That a lot of moving parts went into before we got to the point of delivering. So including an engagement project, so with the Roma and Romanian communities, as a part of the initial kind of write up and the proposal of this project. We learned that there was health professionals in general that had difficult, were concerned about, the difference between Roma and Romanian communities. So we did a piece of work on that to learn about the barriers and facilitators in both communities about accessing MMR immunisation. And that really helped us inform the context of this intervention in terms of content, and also identifying the key bits of recommendations of how we might want to target and have these conversations with members of the community. So we split this up into, we had originally said an hour weekly basis, but we learned that actually it's really difficult to get that time, that sign off for health professionals working in GPs for training. So what we did is we amalgamated week 1 and week 2 together, and week 3 and week 4 together as a 2-part intervention. So the first part, we focus on the introduction to the concepts of behavioural science and motivational interviewing. And it's relevant in the context of discussing MMR and identifying opportunities and being able to practice, in terms of role play with other members of the training, of how to be able to have those conversations and be able to increase the confidence in applying those skills associated with motivational interviewing techniques. And then the second week, we did a recap, and then we focused on challenges and solutions on implementing a motivational interviewing and thinking about that and how individuals can overcome those challenges, and giving the opportunities to, again, do some role play, do some practice, think about some practical examples of how this can be applied in real life, and learning from each other in terms of their own kind of experiences and contexts and stuff. So we had a nice range of different professionals around the table. So each kind of experience was very individualistic. So allowed the opportunity to happen there. So that's a little bit about the gold project from last year. I will pass over. Oh no, I'm going to do this one as well. That's me. Sorry. That's a very quick kind of overview of the gold project. That was focused on MMR, motivational interviewing, but just to highlight that that's the main piece of work that lasts throughout the whole year, and we were able to get an evaluation team on board as well. So really looking forward to seeing how the impact of this intervention, and thinking about the practicalities of being able to, how do we implement this successfully as well. So in terms of silver projects, we've highlighted a couple here. So for example, health literacy is something that we're very kind of supportive of in this team. So we had a training health psychologist student that supported us designing and developing a webinar for the introduction to behavioral science and health literacy. So this is a student who did a 6-week placement with us, so enabled them to get the credits that they needed for their course, but also we were able to design this webinar for any kind of new starter in the team, and then they also delivered a lunch and learn similar to this as well at the end of their placement. So that was a really successful piece of work there related to health literacy. In terms of smokeless tobacco, we're working on a piece of work to increase the awareness of the health risks associated with consuming pan and gua in the Bangladeshi communities in Birmingham, to reduce the consumption of this. And we're working with a trainee health psychologist again so we've done the engagement work in kind of eliciting what the barriers are and the facilitators, and the training health psychologist is designing a pilot intervention to increase the awareness, so in the form of a leaflet. So we're in the process of ensuring that the right information is on there, that's health literate, that it's got all this kind of behavioral science lens components associated when designing a visual piece of work as an intervention. So that's quite exciting. That's a nice piece of work that's been really interesting to work on. And also we're working to upskill communities through comms and webinars. So for example, working with colleagues to publish short communications in a peer-reviewed journal, and raising the awareness through the division through conferences and poster presentations and webinars such as this.
So yeah,
I'll pass it over to you
to discuss the bronze project. So as we've said, bronze is more like asking for light touch advice on where behaviour change can be applied within a particular work stream. So just to like touch upon a few, one of them would be our pilot behavioural science request form within the public health division, and we will go on to speak about that, but that's so that like other areas can kind of get in touch with us, and we can see like how we can help them if they've got certain projects where they just want to look through the behavioural science lens. We can definitely help within that. So that's one of our bronze projects. Another one is identifying opportunities to upskill team through learning, professional development and experience, and also holding initial conversations within public health and corporate colleagues to understand how behavioural science can be optimised across their work streams. It's just light touch ways that we can incorporate behavioural science, look through the behavioural science lens, and yeah, just get involved in trying to make people aware of behavioural science. And that'll lead nicely onto additional projects that we are involved with. So obviously one of the big ones at the moment that we're involved with is we're on a measles outbreak response. So we're, along with a few of our colleagues, we are sort of trying to organise the logistics behind offering training. So we're involved in adding sort of like a motivational interviewing focus within an information session on measles, MMR and measles training. And I'm involved in sort of the logistics of that training, delivering the training, organising volunteers, and we're also having that evaluated by UKHSA. So we're involved in that at the moment. So as we said, we are pushing motivational interviewing training. So we've done like a few sessions with like call recall staff on motivational interviewing. And obviously this is separate to our MMR Gold project, which obviously includes motivational interviewing as well. We have a collaboration with the health protection team on an oral health leaflet, just to again have that behavioural science lens within it, applying the combi that Isha went over earlier. So yeah, Be Active Plus collaboration. This is a project within our physical activity team that we're going to sort of help with, and again add that behavioural science focus. We've also got a breastfeeding project oversight with a master's student at Aston University, so we're overseeing that at the moment, and that's in the process of being done, so that should be a good piece of research. And we are developing a proposal to offer another master's project in oral health for a student at Aston University, and we're looking at sort of developing having placements and health psychology students sort of with BCU and other universities. So obviously it is already April 2024, but this is sort of like the what's going to happen in the next year for us, for our gold, silver and bronze projects, just to touch on them. So for our gold, it's to design, develop and implement a behaviour change 6-week intervention on reducing shisha use amongst a community. It's not finalised yet, the research question, and we're going to do a bit of research into trying to look and scoping on what we want to focus on, but it will be about reducing shisha. Our silver will be once again focusing on health literacy, and a certain project that we're looking into at the moment is surrounding the understanding of pain perception across different communities, and we're just starting scoping on that as well and doing a bit of research. And for our bronze project, we want to implement monthly behavioural science drop-ins. So this is for the division to ask questions around behavioural science and how we can optimise the behavioural science team within their work streams as well. So now I'm going to go on to talk about attending the Behavioural Science and Public Health Network Conference. So this was it on the 20th of February in Liverpool. So the team travelled to Liverpool to present our poster. So the poster was on focusing on community engagement, exploring attitudes of measles and MMR vaccine to support a culturally informed behaviour change intervention with the Romanian community. So this was like the basis and the research behind our Gold MMR project. So Isha prepared the abstract to be able to send it off to the BSPHN who organised the conference so they could review it, and this was shared with partners that were in a task and finish group to be able to create this poster. So they found that communities were engaged through so the communities were engaged through focus groups with Romania and Roma citizens separately, and one-to-one opportunistic interviews with the Romanian community. And obviously, as I said, this engagement work underpinned our educational intervention on motivational interviewing delivered to professionals working across one primary care network. So the themes that came out of this research were both from the Romanian and Roma communities, but were relevant to each community differently. So one of the themes was health literacy, but they were described in different ways from obviously the Roma community compared to the Romanian communities. And in terms of experience of this conference, this was actually on my second day in the role at Birmingham City Council, so I was thrown straight into the deep end, travelled to Liverpool, but it was really beneficial, really exciting. And actually the conference attendees were made of people that they just had an interest in behavioural science and behaviour change, and they wanted to be able to implement this in their day-to-day role, or bring it back to their day-to-day role or their teams. So they weren't necessarily from a health psychology background or even a psychology background, which was obviously lovely to see, and it shows how important behaviour change and using behavioural science and seeing things from a behavioural science lens was. And so there was like key guest speakers, but also in the afternoon we attended workshops, and there was one centered around the combi, which me and Isha did attend, and obviously that was great for application in a public health role. So yeah, pass you back on to Isha. Oh, you're on mute, Isha.
Yeah, sorry. Fabulous, thanks, Alicia. So hopefully we've been able to give you a bit of an overview of kind of what our roles kind of encompass in the behavioural science team here at Birmingham. I thought it would be good to kind of end with a few kind of overview thoughts of what I think is important in terms of and key kind of roles in this team. So working with partners is key. We can't work as a standalone behavioural science team. We're relying on working with across the public health team and wider. For example, in the Gold Project, MMR Motivation Interviewing Project, it's been such a team effort, and it's been so wonderful that everyone's been playing the role and being able to support. Whilst we've led the project, it's very much it's been relying on the teamwork, and that's been really positive. And that's to say, in all the projects that we're working on, we work alongside a different team. So I think it's really important to highlight that that's very, very important when thinking about how we apply behavioural science into our work. So also engagement with communities to ensure the intervention content is culturally competent and designed in an appropriate way. So, for example, in the PARN work that we're doing, our training health psychologist and myself and our service lead, we worked face to face. We did face to face kind of very informal focus group with Bangladeshi women and got their kind of views and opinions and barriers and facilitators on PARN use and their experiences, which is so informative and very much vital on how we kind of organise the messaging of that intervention leaflet, and also doing various online surveys. And also now that once we've designed the leaflet, the pilot leaflet, we'll be taking it back to the community to ensure that we can get feedback on whether it's suitable, whether information is suitable, what works, what doesn't work. It's very much an iterative process, and just keeping that in mind with our work, especially as when we're thinking about service users and working with different communities. I think it's important for us to be visible. So, we're very eager to talk about behavioural science. Anybody who will give us 2 minutes of their time and think about how we can work together, and definitely be able to whether it's thinking about wording on a survey that's going to go out, or whether it's thinking about specific messaging on an oral health poster, we're very much eager to kind of liaise and work with different teams on that. Yeah, and again, delivering webinars and workshops to increase kind of the awareness of behavioural science and its implementation. I think the more that we can kind of highlight the different pieces of work that we've done, it can help us engage and think about different ways of how we can work with other partners or on future projects. As I mentioned, that we're a fairly new team, not brand new, fairly new, but now it's really nice that we're in that position now where we can talk about some of the work that we've done, and hopefully that will continue as time goes on. So for our BCC colleagues, the way that we kind of engage with them in terms of how we can work together, we do have a service request form which colleagues fill out. It gives a bit of information about what it is that they want to work on together, and that gives us some time to think about how we can put together some strategies to be able to influence that. But that's primarily how we kind of get those new projects coming in. So what I will do is I'll stop sharing and I'll also stop recording, and then we can open up the floor for any questions. So there we go.